great to see so many familiar faces, and it's good to see you all. And I'm looking forward to the day when we can all be in person again. Hopefully, it's not too far in the future. So, as Michael said, this is our opportunity to share with you updates on research that is going on in the Brittle Bone Disorders Consortium. We are a very proud partner of the BBDC, as we affectionately call it. We are the advocacy partner, but we're very involved because we bring the patient voice, the constituent voice to the research. So we're doing this series to bring to you all the different research that's going on in all different areas. And tonight we're really excited to talk about women's health and pregnancy. There's some really interesting research going on, and research that will directly affect your care. So with that, I would like to turn things over to Dr. Deborah Krakow. She is a member of our OIF's Medical Advisory Council, and she is professor and chair of obstetrics and gynecology at UCLA. So Dr. Krakow, I'm going to turn it over to you to do your presentation, and then we're going to take lots of questions.
So wonderful. So thank you all for joining us this afternoon or this evening, depending on where you are. It's really a pleasure to be here, and it's a pleasure to be part of the BBDC. It really is an incredible organization from the OIF and this academic research partnership, where I think we're all learning and benefiting from each other. So I am a member of the BBDC. I am at UCLA, one of the clinical sites where we see patients through the Brittle Bone Disorder Consortium. And so I wear multiple hats. I wear the hat of somebody who cares for patients with osteogenesis imperfecta. I have a laboratory that collaborates with many of my colleagues who I believe are online, but also in addition with Dr. Lee's lab, where we're trying to understand the mechanisms that affect bone and other tissues in osteogenesis imperfecta, primarily using mouse models. But as the chair of the OBGYN department, I really felt like a service to the community and to research is to understand issues that directly impact women with OI. And are there specific concerns that would make a physician treat a woman with OI either not differently, but be more aware of how alterations in collagen or genes that encode molecules that affect collagen would actually impact care. So I'm wearing that hat. So I just have a few slides just to introduce the topic, so we can have an open discussion. So Mr. Stewart, I just share my screen, right?
Yes.
So don't worry, I will not bore everybody. I only have a few slides. But I want to talk about pregnancy and OI, and essentially, what is it that we know and what more do we need to know? And I'm going to argue, hopefully, that we need to know a lot more, and that I'm encouraging all of us, particularly members of the OI community, to help us accomplish this goal. So through the Brittle Bones Disease Disorder Consortium, we decided to study pregnancy outcomes in women with osteogenesis imperfecta. And this is not the first time that this has been done. There are a lot of articles written on some very small series of individuals looking at osteogenesis imperfecta in pregnancy. And admittedly, they're all very good studies. They're very well done, but they were more focused really on the outcome for the fetus and less on the outcome for the mother. So we actually designed a survey, and for those of you who participated, thank you, and I'm very grateful. Querying women who have osteogenesis imperfecta, any form of it, and their pregnancy outcomes. And the survey is what we would defer as sort of retrospective, which means people had to remember their past experience. But one of the things that we've argued, and I'm happy to report that our work has been published, is women really do remember their pregnancies and their deliveries really well. It is a important event in most people's lives, and they really do have very good recall. We use the Brittle Bone Disease Disorder Consortium and the Contact Registry that many of you are members of. And we sent out a very extensive questionnaire that included questions about everything like artificial IVF, or using artificial reproductive techniques, balanced against, did you fracture? Also asking about the pregnancy, how long infants stay in the NICU. And we were happy that 170 individual pregnancies were reported from 132 individuals. And I think what sort of differentiates our study from some of the past studies were that, based on what we know, we had the largest group of women who saw themselves as having more moderate to severe OI and yet had pregnancies. So one of the things that we found that I really want to talk about, I think, oh, I'm sorry, is what the outcome was. And if you look, this is a lot of data, and we collected a lot of data. But I want to point to the arrows because these are the things that actually really we thought made a huge difference in terms of care. For whatever reason that we don't understand, we saw more women who reported that they had diabetes in pregnancy. So it doesn't mean that they're diabetic, but they had something called gestational diabetes, where they did not metabolize glucose as well. The one that really has both concerned us and I don't want to say excited us, but has fueled us to do more research, is that there was a statistical increase need for transfusion after delivery when compared to the population that doesn't have OI. And in the general population, the incidence of needing a transfusion is actually not that high. It's about 3%, but we saw many more women reporting the need for transfusion if they had OI. Obviously, the cesarean section rate was greater than the general population. And I think that this is not surprising, since many of our women who responded had moderate to severe forms. But we saw other things that we're trying to work through. More of our infants had NICU admissions that had not anything to do with they themselves having osteogenesis imperfecta. And so we don't know if women with OI are delivering earlier and their infants are going to the NICU because of gestational age at time of delivery, but there were more NICU admissions that had nothing to do with the fetus themselves having OI. And, you know, we saw more infants presenting in the breech or butt first position. And this has been previously reported. So we're really working through why there was an increased incidence of need for transfusion. The other thing that we saw was that there was an increased incidence of fractures during pregnancy. 10% of the women reported fractures during pregnancy, and 4 of them reported vertebral fractures. A percentage of them, 12%, reported fractures in the first 2 months after delivery. And for those who reported fractures during pregnancy, they reported it in the 3rd trimester, not in the 1st or 2nd trimester. And so what we know from the general population is that people who get pregnant are young, and they should not have osteoporosis. So the incidence of fractures in the non-OI patients who are pregnant is extremely, extremely low and almost exclusively associated with trauma. So one of the things that became clear to us is that we think as a group, or I think that we need to understand where these fractures are, when they're occurring, and can we do something about them, particularly after delivery. Clearly, one of the issues that we're all going to face is that pregnant women do not want to take medications. The medications that we use in osteogenesis imperfecta, I wouldn't say are absolutely contraindicated in pregnancy, but have not been tested, and they may not be safe for the fetus. And so I'm really interested in whether we can make a difference after delivery and prevent fractures. And I'm happy to say that with Dr. Lee and the consortium, we actually got funding to actually study why there's an increased risk of hemorrhage in the postpartum period in OI. If you look at maternal mortality in the United States, it's still a very important issue. 700 women died in the United States this year from pregnancy-associated complications. And the most common cause of maternal death is hemorrhage. And so we are really concerned that we can do what we can to try to understand why there's an increased incidence of hemorrhage in OI pregnancies, and that can we make recommendations if on trying to diminish the incidence of hemorrhage and the need for transfusion. For those of you who are on the line, I do not think that pregnancy is at all contraindicated in OI. I think the vast majority of women who have OI do well in pregnancy, which is something that we learned from our study. But I think as you know, Ms. Hart said, you know, can we be better by understanding what the clinical issues are for women with OI? So how are we doing this? Well, you know, getting uteruses after people deliver are almost impossible, thank goodness. So we're going to try to do this in a mouse. And this is just sort of a cartoon showing that there are, you know, differences between a mouse uterus and a human uterus, but there are some very important similarities. And so we're hoping that our mouse models can help us. And I know Dr. Phillips is on the line, and she too has some elegant data on mouse uteruses in OI, and that there are some differences. So we're doing this by looking at the uteruses in our mice models of OI. And so the top row are uteruses cut in cross section. So think of making a fist and then just cutting it in half of what we call a wild type uterus, which is just quote unquote, you know, non-OI, and then two of our OI models. And what we're exploring is what the uterus looks like when it's not pregnant, which is the top row. And then the second row is labeled PPD1, which is we're collecting uteruses on postpartum day 1. So 1 day after they deliver. And you can see that there's a huge difference between a non-pregnant and a pregnant uterus. And what we're trying to determine is, are there differences between our OI uteruses in our mice against those that, you know, mouse uteruses that don't have OI. So for me, this is my most important slide. I am happy to report that this summer we have 8 people devoted to studying the mechanisms of osteogenesis imperfecta in all sorts of different tissues, including the uterus. So, you know, I'm really grateful to all of them who are actually doing the heavy lifting, and I get to talk about it. And then that's it.
Great. Thank you so much, Dr. Krakow. And if you have questions, please put them in the chat and we'll get to those. But I think the first question I have for you is, in your opinion, what's the most exciting research that we can turn into better care? I mean, when we're looking at, you know, the surveys that you've done, is there anything that you're looking at that you said, this could be, we could easily, you know, improve care if we did this because of what the research that we've done? Is there anything that stands out to you?
Yes. So I think the two things that stood out to me from that research that were to me actionable. And, again, it's going to take a lot of group think, including patient participation. But do we educate individuals on OI pregnancy to avert needing transfusions? And so there are so many drugs that help the uterus clamp down after delivery, including newer drugs like tranexamic acid. And it's really important to me that if we can educate people, the providers who are caring for this women, that hemorrhage is increased in this population, that the hope for me would be that they would be able to employ these compounds, these drugs, and there's so many of them, to try to act earlier when they see a woman with OI who just delivered and she seems to be losing more blood than they're used to, not to wait till they need a transfusion. Sort of the employment, and usually, obstetricians will wait and see if it slows down. And, the argument I think could be made is that they may not slow down as quickly as your patients who don't have OI, and to employ maneuvers to decrease the blood loss maybe a little faster than you would normally think about, and just really being more aggressive about hemorrhage. The other one that I know is really, some people would argue is crazy, is are we more aggressive in the postpartum period of trying to address bone mass? Because a good portion of our patients have fractured after delivery, and it's the first 60 days. And so again, this is in my mind, a very high risk area. And could we be more aggressive in either treatment, awareness, and try again to diminish those? The vertebral fractures are really worrisome to me because you have a brand new baby, your back is killing you, and you have to carry this baby around and feed it. And it's not trivial.
Excellent, thanks. There's a question in the chat about, does the rate of regional anesthesia relate to higher proportion of back surgery? Which, if I understand correctly, makes it more difficult. Do you want to talk to that?
I'm sorry, Tracy. Does getting regional anesthesia hurt your back? Or if you've had back surgery, should you get regional anesthesia?
Inav, are you on the line? If you want to unmute yourself to ask that question, because I'm not sure. She can't unmute.
Inav, can you type?
Hi. No, I couldn't unmute because of the settings, and thanks for whoever fixed that.
Okay.
And thanks for the talk and all the data. I downloaded paper. So in the table you showed, right, there was a difference in rate, or there was a much lower rate of regional anesthesia in patients with OI compared to general population. And I was wondering if that has something to do with like the pre-existing conditions of, say, back surgery or back features that, again, if I understand correctly, make it a lot more difficult to get regional versus general anesthesia.
I think that's a great question. And so I am going to assume, with no data to support this, okay, that this study had more individuals with moderate to severe OI, which would mean statistically more likely either to have scoliosis or perhaps hardware in their back. And I know that once you have rods in your back, while regional anesthesia is not contraindicated, anesthesiologists don't like to do it, and they use general. And one of the interesting things about the study is that it was all comers. So it reflects the care that all the patients are getting across the country. And so it's not just care at, let's say, an academic medical center or a community hospital. And so I think that, to answer your question, I don't have an answer, but that it may be because we had more severe patients, that there was more employment of general anesthesia. But I don't know, which is my plug for the following. We are going to resend out a new pregnancy survey to answer a lot of these questions. And we're begging people to please participate, because we want to get as much data as possible. And the difference in this study is we are actually going to directly contact the patient. So the patient is going to be, be willing to be directly contacted, and we're going to obtain medical records. So no one has done this yet. And so while it's still what we would call retrospective, it's like still past pregnancies, we're actually going to be able to document, because one of the things that people don't like about surveys, though I think they're extremely valuable, is the argument is that you're basing your data on people's recollection. And again, I'm going to argue that I may not remember what I ate yesterday, but I remember delivering my children. I remember the name of the nurses. It's a monumentous event in people's lives. And so I think that, of course, there is a recollection argument, but it was interesting. We had to argue with the reviewers that women do remember if you give them blood. They know if blood is hanging. They're not going to forget that. It's not going to be a recollection issue, but it was a little bit of an argument.
Great, thanks. Another question in the chat: what steps should be taken for a safe pregnancy depending on the OI type? So it's a very broad question, but anything you can talk to there, Dr. Krakow?
I think that you just start from the beginning. So for all pregnant women, you want to be as healthy as you can. You want to be at your ideal birth, you want to be at your ideal body weight. If you have any other problems, including problems with your thyroid or asthma, inflammatory bowel disease, if you have any other medical issues, you want them well controlled, and if you need medication, you want to start the pregnancy on medication that's not contraindicated in pregnancy. So I think that that's a given, right? So that's the first thing that I would say, assuring a healthy pregnancy. The next step is you and your partner have to decide whether or not there would be a recurrence risk for OI in your family and what your feelings are on that. And that's highly personal. If you would want in vitro fertilization, so you can select embryos with and without OI, as well as other chromosomal problems. It's a highly personal one that we support, that patients get to make their own decisions. And I think once that is established, the next big step is always reminding patients who have OI or any genetic disorder that other things can happen. You still can have a child with Down syndrome. You can still have other chromosome problems, and to make sure that those are addressed, because it isn't always just osteogenesis imperfecta. Beyond that, I think our data really does support that women with OI overall do extremely well. And that I'm concerned that because this is historic data, that some of the NICU admissions and low birth weights were because obstetricians got scared, particularly of women with the more moderate to severe forms, and may have delivered them a bit premature, because they didn't want to wait for them to go all the way to term. Because it's like, oh my God, you have a short trunk, or you're in a wheelchair, or we're gonna take this baby out before you can't breathe anymore. And my clinical experience over the years there is just no reason to deliver a woman early if they don't have a mother or maternal or a fetal indication. and that women should with OI, even if they're moderately severe, should be allowed to go as close to term as possible. I think that if you have a moderate to severe form of OI and you don't think you'll be able to, rotate your legs or push the baby out, then a cesarean section is absolutely, safe and indicated. Again, educating your doctors that, I have OI and there may be increased bleeding. So please be diligent and stay on top of it.
Thank you. So we had a question that came in earlier, and this is a broad question too, but in your clinical experience, what are the biggest changes you've seen in treating women with OI, either through pregnancy or just women's health in general? What are the biggest changes that you've seen as a practitioner?
I'm really excited, and I think one of the great things about this consortium is I think my colleagues have become great sort of advertisers of the importance of women's health, and they at their own centers have been able to articulate, that pregnancy is well tolerated in OI, but at the same time, please be aware of the following. I think with advocacy, I think that women with OI, hopefully are getting better care. They're not hopefully anymore being told not to get pregnant because they had a genetic disease, which I think probably was the view of obstetricians 20, 50 years ago. And I think there's been a real change in our awareness, hopefully at a national level, that people want to have families. I mean, that's really important to people, and they should. And that we should be supportive of individuals having families, as long as we can counsel people that there are some risks and that we can manage these risks. So I think that that's been a change. Still kind of fighting the uphill battle on menopause, but that's for a later conversation.
Thanks. So we do have another question in the chat. My husband has achondroplasia and I have OI. What would be the impact on our child if they receive both achondroplasia and OI from us? If you're not sure, are you familiar with how OI mixes with other skeletal dysplasias? And are there any resources you would recommend to learn more?
I mean, I think we can talk about this privately. And you can contact me, and I'm absolutely, there's one child out there who I know has both. And, you can't pass a medical judgment on one person that I'm aware of, but I'd be happy to talk to you privately. Achondroplasia is a disorder that primarily affects cartilage and not bone. And obviously OI is a disorder that primarily affects bone with some effect on growth, but it's not considered a cartilage disorder. So for whoever wrote that, Tracy, I'd be happy to talk to them personally.
We can help you connect. Thank you, Dr. Verka. We have another question. At the opposite end of the pursuit of pregnancy, are there any contraindications for an elective hysterectomy in women with type 3 OI?
Oh, no. I mean, the question is always, again, a very private conversation of why would you want to have a hysterectomy? And there's a lot of people don't need to have a hysterectomy because they have fibroids or they have excessive bleeding that's not well controlled by birth control pills or other medications. And again, very private. The only thing that I would argue is there's nothing wrong with having an elective hysterectomy if that's the best choice that the patient and the doctor make together. But if you're less than 50 years old, please leave your ovaries in unless you have a reason to take them out. For example, strong family history of breast or ovarian cancer. That's again another question about leaving your ovaries in or out. But in OI, the estrogen that's made by the ovaries is actually beneficial to bone. So, again, a complicated conversation in terms of how to approach it. But just awareing, it's not a last resort, but it is still surgery. And for some people, it is absolutely the right choice of dealing with fibroids and heavy bleeding. It can be very difficult to manage otherwise.
Thank you. Great. This is sort of a broad question as well, but what are the next frontiers of OI research around women's health and pregnancy? What do you see in the future for us as an organization to advocate for, or to help you in your research?
So in terms of helping all of us in our research, we learn from patients, and it's the patients who actually tell us the questions that we should be answering in our animal models, and addressing, I would say, I think the most important thing to me is that we address recommendations as a group on what we think the best recommendations are. And I hope we come to that, where as a medical advisory board, and through the BBDC, that we come together to make recommendations on how to manage pregnancy, including the issues of hemorrhage and fractures. I can only get the data if people tell us what happens to them. And so to me, this is really important. I really do think that what we saw in OI was maternal, what we would call morbidity due to hemorrhage. And since that is the #1 cause of women dying, I think women with OI benefit from this strong effort to control hemorrhage after delivery. We're using more and more drugs. We're using drugs that people use in operating rooms for, transplants, right? Anything that we can do to try to stop hemorrhage. So I think that that's really important. In terms of women's health, what I think has been understudied is really how to approach women in different periods of their life, in terms of what is appropriate birth control. Are there any contraindications to certain birth controls for women with OI? But more importantly, I think the biggest unexplored area that hopefully we will address is menopause. If women live into their 80s, they spend almost as much time without having periods as having periods. And the role of estrogen in terms of its effect on bone is very, very well known, where estrogen keeps the osteoclast, the bone taking down cell, in check. And in its absence, you cannot take more bone down than build, which is very simplistic, but it's not well explored. How menopause is affecting our OI patients. As a clinician, we start to see more fractures in women during menopause with OI, and people who have historically done very well in their 20s and 30s now are coming in their 50s and 60s with, low impact trauma fractures that they weren't having when they were 38. And how do I keep these people really, really healthy? This is abutting against the issue that we have, in that most of the endocrinologists in the internal medicine world don't believe in estrogen past 5 years of menopause, because of the increased incidence, perhaps, of cancer, maybe some cardiovascular issues that remain, I think, fuzzy in terms of what happens. And so how do we optimize bone and particularly bone and connective tissue health in our women who are postmenopausal?
Great, thank you. You mentioned a couple of times drugs that would be contraindicated with pregnancy. What are you talking about? Just so we're clear.
So 3% of all infants are born with a congenital birth defect. And when that happens, you know, there's always concern. What did it happen because it's genetic? Did it happen because the mother was exposed to something? And obviously one of the biggest issues that people are exposed to is drugs. And no studies by and large on most drugs are done on pregnant animals by and large, or pregnant women. It turns out that if you look at the bisphosphonates label, it is contraindicated in pregnancy. You should not take bisphosphonates when you're pregnant. However, if you go through the literature, there are hundreds of reports of women who were given bisphosphonates either because they needed them because they had metastatic bone cancer and it was a way to control their pain and they were pregnant at the same time, or they didn't know they were pregnant and they were on bisphosphonates for low bone mass because they thought, I'm menopausal, I'm not going to get pregnant, and here you go. From what I can tell, and I know I have other colleagues on the line, it turns out that there was really no birth defects in those women that were reported. I am not advocating, so don't anyone go out there and say that Debbie's saying give people bisphosphonates in pregnancy, but there isn't strong evidence that they are contraindicated, that we are not going to give them. There was some low calcium in some of the newborns, but it was what we would refer to as transient, and went away. So again, if someone is fracturing in pregnancy, I think it's a really tough call on what to do, except immobilization.
Okay, thank you. Thank you for that clarification. A couple of questions in the chat. So back to your study was done with moderate to severe people with OI. Do you have an idea of how your research would affect mild or type 1 OI? I think you had all forms, right?
Yeah, I had all forms, and Ms. Cohn, I apologize to you if I wasn't clear. 70% of our patients had mild OI. They were the vast majority, but 30% had moderate to more severe OI. And that was, I thought, one of the advances of our work was that the other older studies were predominantly mild OI. So we actually had a more spread of the different types, which we saw as a strength. But still, 70% of the patients who responded did have mild forms of OI.
Great, thanks. And this question is from Charlotte Phillips. Is there any difference in the breast milk and with lactation with women with OI? Calcium, fat, protein, etc. Does this impact the fracture rate postpartum?
Oh, goodness. So I think Charlotte's a great question. So I think a lot of the early work on how we think calcium goes to the fetus and how it goes to breast milk was work that was done by Hank Cronenberg a very, very long time ago. And I believe that we still continue to believe that that is the truth, but the work has not been, replicated recently. In the postpartum period, almost all the calcium that goes to breast milk is actually coming from maternal bone. Particularly early on, versus in the first and second trimester of pregnancy, most of the calcium that's going to the fetus is actually coming from increased gastrointestinal, or your small and large bowel absorbing the calcium. In the third trimester, you switch to maternal bone, and breastfeeding is the calcium is coming from maternal bone. So that may be why we're seeing fractures in the third trimester and postpartum. But again, a complete hypothesis, no data, but it is a good question. And, for women who've had OI, who've breastfed, I am not aware, but it's a very good question about whether their children grew at any different rate because their breast milk was different. But my gut tells me no, but I have no data on that.
So speaking of hypotheses, there's a question that came in earlier. Have any research findings surprised you? Has one of your hypotheses been wrong, or and what did you learn from that experience as a researcher?
Oh, I am wrong every day. For the people on the call who are in my lab, they will testify to that on a daily basis. So I was actually surprised by the regional anesthesia use. I thought it was going to be much, much higher. And I was absolutely surprised by the number of increased incidents of NICU admissions for non-OI causes, which again was something that made me think about like what's going on. I understand if the child has severe OI, but I am concerned that there is what we would call a little bit of iatrogenic, like hospital-induced prematurity or doctor-induced prematurity, which some of those children are going to the NICU for a couple of days and don't necessarily need to do that. And that really did surprise me. The other things that surprised me, which blew us away, which I didn't present, which are all the positives, 60% of our patients with OI exercised throughout their entire pregnancy. It was really an impressive number. And again, remember that 30% of our patients had more severe forms. And we actually broke it down for those of you who are interested in different types of exercise, from running to walking to Zumba classes. We tried to be inclusive, and it was just really great. The third trimester, there was less exercise, but I was pleasantly surprised by how many people actually maintained their fitness with OI during pregnancy. I thought that was just great.
Absolutely. The findings that you had about gestational diabetes, is that something that as a community we need to be concerned about for lasting effects, or?
I think, another very good question. The answer is that has not been reported in the other studies. And so the interesting thing is, did we land on something new? Or is this just happens to be the group that answered the questions, and it's not going to be what we would call reproducible? So that's why you want to do another survey. It turns out that if you develop gestational diabetes with or without OI, so just to the whole community, if you develop gestational diabetes, you are statistically more likely to develop diabetes as you get older. So it's uncovering a predisposition to how you use insulin differently than other people. And so I think it is really important that we understand if this, though it was statistically significant, whether or not it is really true, because it does have long-term implications. Then, we tell patients who are gestational diabetics that, you need to be careful as you get older, because you're at increased risk for developing, what we would call type 2 diabetes or old age diabetes.
And I'm sure that's something, on your care team, if you do have an endocrinologist, if you're lucky enough to have a good endocrinologist, that's something you should share with them as well, right? I mean, okay. Question, what is the percentage, do you know, of women who get postpartum fractures?
Among the women who fractured, two-thirds fractured postpartum, and half of those were vertebral fractures or reported. Now, I know that one of the things that really interests me, and I need, again, all of you who are in the community, at least 5 different women over my course of going to meetings have told me that in the postpartum period, they developed something called osteoporosis of the hip. And that's actually a medical emergency where the marrow in your hip gets full of water, and it's treated with drainage and bisphosphonates. And so I am very interested to, again, to do a more detailed study where we can directly talk to people to find out what the incidence of that is. It's an extremely rare complication of pregnancy. And again, if you look at the literature, of which there's just isolated case reports, almost every article says the following: the patient had low bone mass. And so they may have not been called osteogenesis imperfecta, but individuals recognize that that is a risk factor for osteoporosis of the hip. You can get it in other bones, but that's the most common place.
Wow, interesting. I don't see any other questions in the chat. My colleagues that are on the phone, if you have other questions that have come to you, jump in.
So Dr. Krakow, I actually have a question for you. And also, just for a little context for those on the call, Dr. Krakow, again, will be speaking at the OIF virtual conference in 2 weeks at the Women's Forum. She is an incredible resource, and we are so thankful to have her. For those of you who have attended a Women's Forum in the past, those are, you may know that those are actually, so we do not record those. We do not post them online afterwards as living, breathing documents. So you may not have interacted with Dr. Krakow before. This is your first meeting with her. My question is, I imagine we may have people on the call who are, new or young families thinking about having a child, and maybe one parent has OI or two. And I'm curious, you make yourself available to everyone, and we are so thankful for that as a community. But, for those who, for a variety of reasons, maybe they just, live too far away from Los Angeles, they cannot see you in person. What advice do you have for them? It's a very broad question.
No, it's a really good question. So I think that, it's a great question. So, doctors really want to take care of you. Doctors really want to get the best possible outcome. None of us went into this business not to get great outcome. But, I don't want to say advocate for yourself, but you are going to know more about OI than your obstetrician is. Your obstetrician's not a geneticist. And even among geneticists or orthopedic surgeons or endocrinologists, you will know, I promise you, unless your doctor themselves has OI, you will know so much more about OI. And so I think the most important thing as a couple, even if, the woman doesn't have OI and the spouse does, educate your physician about, it's even obstetricians don't even know what the recurrence risk is for so many disorders, right? What is the recurrence risk? This is how we as a couple feel. I'll give you a perfect example of something. And again, many of my patients I care for with OI have chosen just to get pregnant. And if the fetus has it, it has it. If it doesn't, it doesn't, and everything is fine. I write in all my notes, this is fine, the patient's great, no problem, call me for anything. But when they go deliver, if they deliver vaginally or by cesarean section, do not put forceps on the fetal head unless you know for sure that the fetus doesn't have osteogenesis imperfecta. And I know it's something that everyone's probably going, what is she talking about? It turns out that if you put a vacuum or a forceps on somebody's head, most babies do great. But about 5% actually have some minor complications. Some have life-threatening, and they're very, very rare and tragic. But you can fracture the skull, you can compress the skull. The vacuums cause really big what we call hematomas, because you're sucking the baby out like this, right? And if you've ever seen a baby after a vacuum delivery, they look like a rocket, right? And you can actually feel the fluid and a little bit of blood there, and most of them do fine. But in the face of OI, you don't necessarily want to do that because you don't know what the fetal head could be a little softer, or the fetus could bleed more. So, you know, it's just, again, educating your doctors on what OI is, what your expectations are, and to seek counsel. And I think, Tracy, do we have an OI in pregnancy worksheet?
Sure, we sure do. We have a whole newborn toolkit as well. Mhm. That goes pre-delivery. Yeah. Yeah, and that's available. And I think we can actually put a link to it in the chat. That's wonderful advice. I mean, I think that's a really good point, Michael. Dr. Krakow is such a wonderful resource, but people live in their own community. And so we need to make sure that we provide you with all the tools that you need and the resources you need to advocate for yourself. That's our job.
Dr. Krakow, I'm seeing some other questions in the chat, and I know you've answered these before, but I think it's a good refresher for everybody. One is asking, for if one parent, the mother, has OI, what are the chances of the child having OI? And I always think about the dominant versus recessive.
So if the mother has what we call a dominant form of OI, usually due to the mutations in the gene that makes type 1 collagen. So you have, you know, 2 genes and one's got a problem. The offspring has a 50-50 chance of having it. And each pregnancy is its own genetic story, right? So you could have 3 unaffected children or 3 affected children. So each pregnancy is its own mixing of genes. If you have a recessive form of OI, unless you have a pregnancy with the spouse being a carrier, your fetus is not likely to have OI. And since the carrier for these recessives is really very low, unless you come from a very similar ethnic background where there's a possibility that you have a recessive form where you have 2 copies that are not working ideally, and your spouse is from, you know, a similar region or is related to you, then I would argue you're likely not to have a child with OI.
Great, thank you.
Well, we have just a few minutes left. And Dr. Krakow, is there anything you'd like to sort of end with before we wrap up? Anything that we haven't covered that you think from your studies or what your next survey, anything you'd like us to know?
Yeah, so I learned from patients, and, you know, patients direct us in the direction of what we should be studying and why. So I am begging everyone that when the survey comes out, please encourage everyone in your districts through the OIF to really fill it out, even if it's a little bit of work, and allow us to contact you so we can get more information. You know, one of the things that I want to close with, I want this to be really, it is positive. The vast majority of women did really well in pregnancy. And, you know, that's the other thing that I want to get out. So people don't see individuals as who have genetic, may have a genetic disorder in their family, not to have families. I think the opposite. I'm just sort of motivated to understand all the risk so we can get people the best possible outcome we can. No different than any other disorder in pregnancy, whether it's women who have asthma or diabetes or ulcerative colitis. We want them to have families and we want them to have healthy children.
Thank you so much. This is really terrific. Thank you so much. Michael, remind everyone again, Dr. Krakow's session at our conference.
Yes, so and I see one of my colleagues put the link to the Women's Forum into the chat earlier. So Dr. Krakow will be speaking on Sunday, July 11th, correct me if I have that date wrong, at the OIF Virtual National Conference this July. That'll be I believe a 1 or 2 hour session, I apologize. and she will be able to answer more audience questions there as well. That will be, I think, a bit more of a focus on clinical questions. Today, we focused a bit more on her research, although I think the places where it intersects is often the most fruitful and interesting. So if you found this interesting, definitely attend that session as well. And I think with that being said, my colleagues have put a lot of other helpful, useful information into the chat. So we're bombarding you with OIF resources right now, and we are not mad about it. If you have any other questions for the OI Foundation, please just respond to any of the Bone Link emails, and it will get to us, we promise, and we will connect you with the best resources possible. Dr. Krakow, thank you so much for being with us your afternoon for us this evening. We appreciate it greatly. We are very lucky to have you with us. And Tracy, thank you so much.
Thank you. Thanks, everyone. Have a really great night. Be safe. We'll see
You guys are
everyone soon.
amazing. This community's amazing. Thank you.
Thank you. And
Bye,
we'll see
everyone.
we'll see you all in the second weekend of July. Thank you.
Bye.